Well, you've already heard the perhaps the most exciting and new part of the presentation, and that was by Yaron, previous to me, and previous to the technical problems. But so those of you who've been paying close attention know all about the TMAU genetics. That was very carefully and nicely explained. And I will go into some of the basic biochemistry, which many of you may already be somewhat familiar with, but that's why I'm here to ask questions of. So once again, we are talking about a rare disease, and this is a slide from the National Institutes of Health here in the States, showing rare diseases by the number. So in the U.S. population of approximately 300,000 people, approximately 1 in 10 Americans have some sort of rare disease. Now, for the worst part of this, my screen just went blank. Is there a problem? Okay, here we are. We're back. Okay, so yeah, I see that. So the thing I think you should pay attention to is that on the bottom there, not the 30% of children with rare diseases who will never see their 5th birthday. That is tragic, and it's certainly not the situation for trimethylaminuria. It's a rare genetic disease, true, but it is one which presents with psychosocial problems caused by sporadic production of odor. It doesn't present with mental or physical challenges like many other diseases do. So, but one has to go through a large number of physician visits, which are often costly and frustrating, before a diagnosis. And the average number of misdiagnoses is also large. And the average time for a real diagnosis is often 7 or more years. So this can be a frustrating and aggravating situation to many. So my lab studies human body odors, and I have been doing this for 45 years since I came to Monell. And most normal human body odors and oral odors are formed by the interaction of skin gland secretions and microorganisms that live on our body. And we have many odor-producing areas, which I've listed in red, that are found on various parts of our body. And prior to the 20th century, when many of us dressed like this fellow on the left-hand side, it was very obvious that prior to the 20th century and the widespread use of scented soaps and consumer products, it was more readily apparent that humans emitted a variety of odorous metabolites, and we do produce a lot of them, depending on where you look. Now, there is a lack of knowledge amongst healthcare professionals, not only about odor production, but particularly about trimethylaminuria. And this aids in the impediment of diagnosis. Most healthcare professionals do not have this included in their training, and the symptoms are not recognized. The episodic intensity of the odor often causes confusion in diagnosis. The inheritance of TMAU is often unclear, and sometimes genetic tests can prove inconclusive, since they may not demonstrate phenotype. They may not tell you how much odor is being produced. So, as I often tell people I have interacted with this disorder, or who think they have this disorder, you don't go to the fellow. What happened? You don't go to the fellow down the street, the doctor down the street. You go to a major medical center where they may have genetic and metabolic disease specialists who may be more aware of rare conditions such as trimethylaminuria. So, although the lack of knowledge amongst healthcare professionals may impede the diagnosis, there is information available now. There wasn't when we first started this effort back in the late 80s. Now there is the widespread availability of the internet and information there. There are patient support groups, And there are other rare disease info on not only on television but also on the web, WebMD and places like this where you can get a lot of good information, or the National Institutes of Health. And without these sources, many TMAU people would be in the dark about this genetic disorder. Some history. In the mid 1800s, there were 2 reports in the Lancet of trimethylaminuria-like diseases. 1970 was the first clinical description and diagnosis of trimethylaminuria by Humbert et al. At the University of Colorado in Denver, where much of our diagnosis is done now. So, and then let's see, 1970 to 85, there were reported sporadic cases, and the discussion of diet, the role that diet played in the disease. Genetic studies happened in the 1990 area. I know Colin Dolphin in the UK was the first to identify one of the genetic causes within the FMO3 that caused trimethylaminuria. And since then there is systematic recognition of this as a rare genetic disorder. We diagnose generally using urinary trimethylamine concentration. Prior to 1985 or so, it was just done by looking at total trimethylamine in the urine, and all urine studies are always done with respect to creatinine in the urine. And from 1984 to present, it is done by looking at the total TMA trimethylamine before and after ingestion of a choline test load. So the choline challenge has become a very important and critical part of the diagnostic procedure. And generally we get the report is sent back to the patient as TMA and TMAO concentrations in micro or millimoles per millimole of creatinine. And all this is, it was once done by Dr. Fennessy in his laboratory, but now he's nearing retirement, and for the last 10 years or so, he has and after the death of his technician who ran the analysis has become principally done by the University of Colorado Department of Pediatrics Biochemical Genetics Lab, and that is where we send all our samples before and after choline challenge testing. And they do it using liquid chromatography, mass spectrometry with electrospray ionization, which is a technique which gives you lots and lots of data all at once. So the data is readily available to the investigators once the patient is tested properly. So there are causes and variability in the trimethylamine odor, and if you just look at intrinsic trimethylamine production from turnover of the biomolecules within us, you get a very small amount of trimethylamine, 1/1000th of a milligram perhaps. However, the major portion of trimethylamine comes from production of by the gut bacteria on dietary products. There you produce milligrams of trimethylamine. And so the huge difference is all dependent on your diet and the type of microbiome you have in your digestive tract. So in our patients, and from about 1985 to 1995, many of our patients were referred by a medical professional. However, since the widespread advent of the internet, many now come self-referred. And patients have visited us from all over the U.S. and other countries, but now we restrict ourselves to North America for diagnosis. And there is a reason for that, especially since 9/11. The going through customs with biological samples or sending biological samples across borders, we have found to be a very large pain in the neck. So many of our patients have been to many different clinical or dental specialists looking for help. And when we were seeing patients, all the patients, particularly the ones discussed by Dr. Go previous to this, that we used in the exome study, all of these people had multi-step exams involving both analytical and sensory techniques. The critical part, of course, was the choline challenge test to determine the presence or absence of trimethylaminuria. Most of our in-house evaluations of patients were done between 1988 and 2008, approximately 350 individuals. Starting around 2003, we began using a home testing kit, and now we test almost everybody this way. People request a kit from us. They send us a fee for the kit, and we send the kit to them, and then we take care of shipping the samples to the laboratory for analysis. So this testing has revealed a large undiagnosed population of people with trimethylaminuria, all done using the choline challenge test. Many of you know that trimethylamine is a gas at body temperature and has a strong, pungent, offensive, fishy odor. And at low concentrations, it may also be perceived as foul or unpleasant. And it's reported to be present in all body odors, all body fluids when you have this disorder. The fish odor syndrome, I think, is a misnomer and shouldn't be used, since only about 10% of our TMAU positive individuals have this presentation, and this was generally after the choline challenge. Only the people with the most virulent mutations perhaps had this presentation. Oops, here we go. The symptoms, as you know, are often sporadic and may escape notice due to low choline intake or specific anosmia in the clinician, which is rare. It's generally the first thing that makes people escape diagnosis, low choline intake. Almost all the people who have come to us, even the people with the strongest cases of TMAU, were odorless at social distances because they came to us fasted. They were generally fasted and they hadn't eaten for 12 or more hours. And so we rarely detected an odor in their presence until after they had the choline challenge. So as I said before, we've looked at in person, in vivo, as you will, more than 350 people. About 32% were diagnosed with some form of TMAU, and the average age of our TMAU affected population is around 43.5 years. But there is a wide range, as you see here. And we have diagnosed many children with this disorder. Some of the self-reports that people come to us with, and this has not changed over the course of the years. There's still this cross-section of odor complaints is still present. 3 times more women than men have been in our population have been found to be TMAU positive, and many of these are African American women, which is shown in this graph. So the proportion of sample, whoops, sorry, I hit the gun too quick. What we're observing versus what is expected from the population that we're drawing from the census numbers, you can see that the Caucasian females are well within what is expected, but the African American females are way more than you would expect in the population around Philadelphia. Also, females' ability to metabolize trimethylamine into trimethylamine oxide varies with the menstrual cycle. This slide, somehow this has gotten screwed up in this presentation, but basically within close to the time of menses is when many females report their worst symptoms, and we generally try to test within that time frame if you're a woman of reproductive age, because that's when you're most likely to get a true reading of trimethylamine oxidizing ability. The trimethylamine appearance after a 5-gram load is often is highly variable, and it often depends on how quickly the digestive process works. And but this slide, the alignment of it has gotten sort of garbled here, but trimethylamine, the maximum the maximum passage into the urine is it can be variable. So when you take a post-choline sample is often very critical, and that's why we do it in 3 8-hour. We take a baseline sample and then 3 8-hour aliquots. With the laboratory we work with, this gets to be more expensive, so some people opt just to take a baseline and 1 sample after choline intake, and we try to hedge our bets here and in telling them when to take the post-choline sample. But how you perform the choline challenge test is important in providing a true diagnosis, and for females, when you test is very important for providing a true diagnosis. So those 2 things should be kept in mind. The other thing that has appeared in the last 4 to 5 years is the realization that there is a specific group of bacteria living, well, it's been demonstrated that they're in the gut, who contain a specific enzyme known as the choline utilization enzyme gene cluster, or the CUT enzyme. And it is this enzyme which allows the cleavage of the trimethylamine moiety from dietary type materials like choline or taurine or betaine. So these bacteria have enzymes that make them very efficient at producing trimethylamine from dietary substances. So if you got a lot of these bugs, you're more apt to produce a lot more trimethylamine than the next person. Looking ahead into the future, can we influence these? Well, certainly we know we can influence them by antibiotics, because it's been demonstrated that antibiotics will eliminate symptoms, but you can't be on antibiotics all the time. So can we influence the proportion of gut bacteria with the CUT enzymes? Can we synthesize or produce or use a small molecule inhibitor of the CUT enzymes? And the other question in my mind, and are these bacteria found elsewhere? And most likely yes, and I'll get into that a little bit in the next few slides. There are many non-related complications that often occur concomitant with TMAU or in TMAU people. There's been reports in the literature of people with Prader-Willi and Noonan syndrome having TMAU, skin rashes, seizures, hypertension, psychiatric dysfunction and impaired metabolism of nitrogen and sulfur-containing compounds, depression, sarcoidosis, IBS, and other lower GI problems. All of these can occur in a person with TMAU. They can occur in me and you also, who don't have me, who doesn't have TMAU. I don't have any of these, but I could have one of these. My wife is hypertensive, but she's not trimethylaminuria positive. So these are things that can have been incidental with trimethylaminuria, but not caused by it. With females, some females have come to me with talking about recurring fishy vaginal odor problems not related to TMAU, because when we test them, they are TMAU negative. And this is a case, there is one paper in the literature which shows that they didn't know about the cut enzyme containing bacteria at the time, but they had a population of women who kept producing a fishy vaginal odor. They were non-TMAU positive. They did not have vaginosis or any vaginal infections, but the fishy odor was still there, and it was obviously that they had it's obvious now that they have some women harbor a population of bacteria with this enzyme in them, and we have yet to provide relief for this. I mean, temporary relief can come from topical antibiotic use that is often used with vaginal infections. They may also be present in the bacterial plaque on the tongue and be responsible for producing a fishy odor emanating from your breath, but we don't know that. That is just my speculation. But in my experience, many of the patients, even those with the worst cases, do live normal, productive lives at a variety of professions. My dentist for the last 20 years is one of my TMAU patients who has had a very bad case, but you would never know it if you were examined by him. The main problems, as many people know, have been psychosocial problems caused by odor production and the odor symptoms. And often how you deal with this is tied to your individual personality. So to summarize, our results demonstrate the necessity to screen for TMAU with an objective analytical test and not to rely on anyone's olfactory abilities or the reaction of other people, I should note. Only about 10% of our patients have had the classic fish-like presentation during their exams with us. Patients may not be aware of their own odor or the intensity of their own odor. In our referred population, most people have had a similar history. Many do not smell badly at all, and we get up close and personal to examine the people we have looked at. So I say this from personal examination experience. Very few patients have had higher levels of axillary bacteria, so they don't produce much axillary odor or underarm odor. And amelioration of symptoms, we have developed a protocol for this. I don't like to go into details except to what I've written here because many people think they have trimethylaminuria, but not everybody does, and you should always get diagnosed. And for many people, because of their personality or because of their symptoms, nothing may seem to work. But so that is why I always caution everybody to have someone you know and trust, which I call an odor buddy, that can tell you exactly when the odor is present. So that way you know if you're trying something, whether it's working or not. Let's see, both TMAU positive and non-TMAU negative patients may have bad breath caused by emanation of volatile sulfur compounds. So that's the breakdown in what we've seen in our patient population. About a little more than half of everybody coming in to see us has bad breath, obnoxious or malodor noticeable at social distances. Female patients in our patient populations are either more affected by TMAU or may present in greater number to someone for relief of symptoms, and many of these have been African American women. There has been reports of decreased FMO3 efficiency due to complications such as viral infections or other drug intake that can compete with the available FMO3 and other enzymes in the oxidation reduction pathways. Most of all, funding is needed for follow-up studies, and I think for many of the people in the community, probably the best thing, in addition to learning more about the genetics of the situation, would be an in-depth study of symptoms and treatment regimens. How well is what you are doing working? And as I said before, how well, with someone you know and trust, is there someone you can talk to about how to, am I odor free today? Are there other genetic odor producing disorders that we don't know about? Possibly, but so far we haven't come across many others. My question to any audience I talk to about this is, we have so many people calling us all the time asking for help. I say help is available, but you have to be diagnosed, and they pay the money for the materials to be tested, and only about 40 to 60% are ever returned. The rest are never, we don't know what happens to the rest of them. So people are spending money but not getting their money's worth. I think that might be it.
Yeah.
Thank you very much.
That was very interesting. Sorry, I'm gonna hide this. If the participants have questions, you can leave them on the chat now. I know that there was a problem and the chat just disappeared, but now if you have questions for the researchers, just type them here and they'll try to answer them. Thank you, Professor Preti. That was very interesting. If you agree, do you think we could share these slides with the TMAU community?
Sure, go ahead.
Okay, that's great.
Yeah.
Yeah, that's great. Along with the video, we'll try to put the slides as well. So,
okay. Sounds fine. Now, you may want to just, I mean, if people have questions, they can also send me an email. My email is very simple, Preti, my last name, at Monell, MONELL.org. So you can send me an email, and I don't always answer right away, but I'll answer it eventually.
There's a question here.
How much?
Yeah, you go.
Wait, here's a question. How much time do you think it will take to have a cure available? It's not going to be in my lifetime or yours, I don't think.
There's another question.
Yeah, go ahead.
Will there be another benign metabolic body odor conditions yet to be discovered?
Well, you should never say no, so I don't know. I can say I don't know because I'm not in the business of discovering these types of things. The Trimethylaminuria just sort of walked into my life, more than 25 years ago, because I study human body odor, and so far I haven't come across any other ones that are as easy to diagnose as this one, where there is a protocol available, but nobody. The other thing that's bad is bad breath. A lot of people have bad breath and they don't know it. Dentists in America don't seem to treat it or know what the heck is going on. So that is often a problem, but it's not a metabolic disease problem. Low choline isn't always helping TMAU patients. Why is that? How do you know that it's not helping you if you don't have somebody to tell you it's not helping? Probably, and it may not help because there are many pathways to produce choline, and depending on the severity of your disease, even a little bit of a couple of milligrams of trimethylamine may be enough to make you impart an odor production. Would you say that there are people with minor and even relatively major FMO3 faults that don't suffer from TMAU symptoms? Minor ones, yes. I would say there might be a lot of people walking around with common allele variants, but Um, the major ones, if you have one, if you're heterozygous, you can have a major FMO3 fault, as you say it here, and not be symptomatic. I've seen a couple of people like that because your other allele takes care of it. It's the dominant allele. Dr. Gu would know more about that. Yaron would know more about that than I do.
Yeah, you're correct. So heterozygous is less severe or even no symptom than the homozygous variants.
Right. Yes. Yeah, I have an interesting family where mom and dad are both heterozygous, and two of their kids are homozygotic for a very severe FMO3 fault. Somebody else typing away. What do I think of dimethylglycinuria? There isn't a commonly available test for it. So, I mean, nobody's developed a dimethylglycinuria challenge. I guess you could try one, but these things cost money and patience to test it on. And so it's not, it doesn't appear, I think there's only one reported case in the literature. If I'm not mistaken, I'll stand corrected if there is more, but I don't think there is more than one case like this in the literature. So I don't think it's going to be a major problem.
Hi, George. I have a question. So, do you think it is possible to have some normal FMO3 to to how to say neutral this disease? To take
you mean introduce it somehow?
FMO3 and then
yeah, you would have to protect it though. I mean, if you want to, how would you introduce it you could introduce it into the digestive tract, but most of the digestive enzymes would chew it up, so it would have to be coated in some way to make its way down to the large intestines where all the trimethylamine is being produced. So unless you did that, you would probably fail in getting any type of effect.
Thank you.
How common do I think TMAU is? I have no idea. It's a rare disease, so it's maybe 1 in every 200,000 to 300,000 people might have a severe case of it. I don't think anybody's done any statistics on it or taken a survey. In a Science Daily article, you said something to the effect that the urine test is the preferred way to diagnose TMAU. Yes, that's right. It is the preferred way because it is the way that elucidates the phenotype. We've just finished saying that you can do a genetic test and show that there are minor allele changes or common allele changes present, but you won't know, and a geneticist or a physician might tell you that these are not going to cause symptoms, but we know in some people they do cause symptoms. So unless you do the choline challenge, you cannot see how well you are processing the trimethylamine into trimethylamine oxide. And it also has revealed the presence of these other oxidation reduction pathway genes that may be at fault. So regardless of what type of change you have which causes trimethylaminuria, it is my contention that the choline challenge test will reveal it. What about methane producing probiotics as a possible therapy? Well, methane production will give you gas. I mean, most flatulence is methane. So just like a cow or a farm animal that chews a lot of carbohydrates up, you produce gas, in quotes, just like they do, and sometimes it smells bad, and sometimes it doesn't. When it doesn't, it's mostly methane. When it does, it's methane tinged with a little bit of sulfur compounds from digesting sulfur-containing amino acids in the diet. So I don't know. Yeah, probiotics is a way to try to alter the gut microflora, but it's like going to the casino. Sometimes you may win, sometimes you may not. I don't think there's been a protocol that's been tested and peer reviewed that has been shown to work. So you can try it and you might get lucky. Can I explain something about the oxidation process? Well, it's simply in the case of trimethylamine to trimethylamine oxide, the enzyme is simply adding oxygen to the molecule. There are free pairs of electrons on the nitrogen, and they bond to the oxygen in this. I forget what orbital. I mean, you can get into some of the chemistry of this, the orbital chemistry of it, but basically it's just adding oxygen to the molecule. Do we know what bacteria produce TMA? Yes, I told you well, it's a group of bacteria that have this enzyme, and if you read the paper by Balkis, Emily Balkis at Harvard, I think she explains in there some of the bacteria that are. She names some of the bacteria that have this enzyme, but it may be like reading an article in ancient Latin to you. You won't make it's not gonna tell you very much, except that they live in your digestive tract.
Is there any more questions? If not, I think we can leave it here. Unless there are like a couple of more questions. I think somebody's typing now.
Yeah, I've got another phone conference in about 20 minutes, and I have to eat some lunch beforehand. Oh, thank you.
That's it. I think nobody else has more.
Okay, you're very welcome.
Thank you, everybody. Thank you to the presenters, and thank you to all the participants. I hope the webinar will be available online very soon. I'll let you know once it's published.
Thank you. Thank you, Marta. Thank you very much.
See you.
Bye-bye.